Hi, welcome to my latest topic, that's amyloidosis. So what is amyloidosis? Amyloidosis is a type of pathological state where you find fibrillar proteins being deposited in abundance, mostly in extracellular spaces, and it can affect different kinds of tissues and organs, and it's seen in a variety of clinical conditions. All right. Now let's look at the general features of amyloidosis. So it's generally seen in a lot of systemic states, mostly in inherited conditions or inflammatory conditions. We shall get to the specifics of that later on. So they're basically extracellular fibrillar protein deposits, which affects the involved tissue, where it can cause structural damage or functional damage. And so mostly it arises from misfolding of fibrillar proteins, which causes them to aggregate, right? So normal proteins are generally soluble, whereas these are insoluble. So as a result, they end up accumulating and clumping up together. And if you look at the name amyloidosis, the first half of the word, it begins with amyloid, which is similar to amylase, and it's actually a misnomer because when it was first discovered, they mostly found these abundant charged sugar groups on the surface. And on staining, they resembled amylose, which is basically starch. But later on, they realized that it was just proteins. Really, it's just proteins. All right. Now, if you look at amyloid forms, what's common to all of them is that they all have the same morphological and staining properties. And it's not a single disease. It's a complex of them. And you can find the various differences of these amyloid proteins based on the biochemical structure or the mechanism of formation. All right. What's common to all of them is the deposition, which gives similar appearing proteins. All right. They all look the same, but on biochemical or immunohistochemical staining, you find that they are actually different. So the physical nature of these amyloid proteins is that they're non-branching fibrils. They're often 7 to 10 nanometers in diameter, right? So they're actually beta-pleated sheets, which are polypeptide chains, and they typically one around another. And you can find this in cases of infrared spectroscopy and X-ray crystallography, all right? And you find that they bind together. And when you use Congo red dye, which is the most commonly used stain to detect this, you find a classic apple green bifringence appearance, which is basically dichromosome. So it's going to show two types of colors constantly, all right? So this is how you can identify amyloid deposits in tissue. Now, moving on to the chemical nature, right? 95% of the fibrillar protein are non-branching, and 5% of them are proteoglycans, glycosaminoglycans, and serum amyloid P, all right? And on biochemical forms, there's 3 major types of amyloid proteins and 20 minor, all right? So now moving on to the major forms. How I remember it is LAB, right? So you have A in front of all these initials, that's for amyloid. So that's AL, AA, and A beta, all right? So I just take the L, A, and B. Now, AL stands for amyloid light chain, which is the most common type. These are basically immunoglobulin light chains produced by plasma cells, and they're often associated with monoclonal B cell proliferation, right? So that's AL. Moving on to AA, that's amyloid associated. It's most commonly seen in secondary amyloidosis, and it involves non-immunoglobulins proteins, and they derive from a larger precursor protein. So sometimes that's serum amyloid associated protein synthesis. And it's also commonly seen in liver cirrhosis. All right. Now, moving on to A beta, it's derived from transmembrane glycoproteins, such as amyloid precursor proteins, that's APP, and the seen in cerebral lesions, which is clinically resembles Alzheimer's disease. I've written here of Alzheimer's disease, that's actually wrong. It's very similar to Alzheimer's disease. There's a whole classification for dementia, and this falls under that. All right. Now, moving on to the minor forms, of which you have to remember transthyretin and beta-2 microglobulins. All right, these are the two most important ones. So starting off with transthyretin, TTR, all right? So basically, it's a transporter protein which transports thyroxine and retinol, all right? So if there's a mutation in this TTR gene, there's an altered structure which causes misfolding, all right? And you commonly see it in senile systemic amyloidosis, where it gets deposited in the hearts of aged individuals, or you find it in familial amyloid polyneuropathies, all right, where basically it gets deposited in the peripheral nerves and can often cause this type of tingling sensation or even a lost sensation, right, which can actually progress. So it's mostly seen in peripheral and autonomic nerves. All right, now moving on to beta 2 microglobulins. It's actually a normal serum protein, all right, which is present in tiny amounts. However, in cases of long-term hemodialysis patients, you find this A beta 2M protein, it constantly gets accumulated in cases of hemodialysis. Mostly because if you look at the dialysis machine, it takes out large volumes of plasma, right, from the blood. And as a result, these proteins cannot permeate through the membranes, semi-permeable membranes of the dialysis machines. And it just gets deposited in the vessels in large quantities, right? Other minor forms you should remember are proteoglycans, serum amyloid P components, and glycosaminoglycans, which I had mentioned earlier under amyloid forms. All right. And now moving on to the pathogenesis. All right. So there's three main ways of which you can find amyloidosis forming. All right. Through two methods. One is production of abnormal amounts of normal proteins and production of normal amounts of a mutant protein. Now, under production of abnormal amounts of normal protein, the etiology can be of two ways. One is of unknown etiology, some suspect from carcinogens. Another is a case of chronic inflammatory states, such as in autoimmune states. Now, in the unknown state, you can find a carcinogen causing monoclonal proliferation of B lymphocytes, forming plasma cells, which then produces immunoglobulin light chains in bulk quantities. And you find amyloid light chain proteins being produced in large amounts, all right? And in case of chronic inflammatory states, such as autoimmune states, you find activation of macrophages, which secretes increased amounts of interleukin-1 and interleukin-6. These are chemokines seen in inflammatory states. And now, once this reaches the liver, it causes increased synthesis of SAA, all right? Now, SAA is the serum amyloid associated protein. Right? SAA is serum amyloid associated protein. And incomplete breakdown of this, in case of these chronic inflammatory states, causes amyloid associated protein, which is the AA. All right. So, in case of unknown cases or carcinogens, you find increased AL production, and in chronic inflammatory states such as autoimmune diseases, you find AA production. All right, now moving on to production of normal amounts of mutant proteins, you find a mutation in the gene. For example, if the gene encoding TTR undergoes mutation, you find mutant transthyretin being formed. And aggregation of this makes it actually resistant to proteolysis. All right, so it's resistant to breakdown. So you find increased deposition of ATTR protein, which is the abnormal protein resulting from mutant transthyretin gene. And all these three states where you find AL being produced, AA being produced, and ATTR proteins being produced results in amyloidosis. All right. So now let me just summarize the way how it deposits. One is through excessive production of normal proteins, which are prone to misfolding and aggregation. Number two, mutation producing abnormal protein which cannot fold properly. Number three, defective or incomplete degradation of proteins. All right. So now, why is this important? From a pathological perspective, the effects are, it causes increased pressure on adjacent normal cells, which causes atrophy of cells. There's something called pressure atrophy. When there's a lot of pressure being exerted on these cells, they suddenly atrophy, right? And there's deposition in blood vessel walls, such as narrowing of lumen, which can cause ischial damage, or increased permeability of these vessels, which causes escape of protein out of vessels, okay, where it can spread to surrounding tissues. Now, moving on to classification of amyloidosis. So, amyloidosis can be broadly classified under systemic, hereditary, and localized amyloidosis, all right? So, let's start with systemic. Now, systemic, most commonly you find AL protein being deposited, all right? So you have primary amyloidosis, secondary amyloidosis, and hemodialysis associated amyloidosis, all right? So now primary amyloidosis is most commonly seen in immunocyte dyscrasias, all right? Here again you can find with amyloid deposits and without amyloid deposits, all right? So now under immunocyte dyscrasias with amyloidosis, you find underlying plasma cell dyscrasias such as multiple myeloma, all right? So in 5 to 15% of multiple myeloma patients, you find amyloidosis, and this is because the tumor synthesizes abnormal amounts of a single specific immunoglobulin, which appears as an M protein. If you look at the serum electrophoresis, you find an abnormal M protein spike. That is actually the amyloid protein deposits, all right? So it also synthesizes light chains, such as Bence-Jones proteins, which can be found in serum or urine, all right? And Bence-Jones proteins are small molecular size and excreted in urine commonly. Now, here is a paradox. So all myeloma patients with amyloidosis show Bence-Jones proteins, whereas most myeloma patients with light chains do not show amyloidosis, all right? So that's where you find the without amyloidosis part. Okay, so majority of patients with AL amyloid do not have multiple myeloma or any covert plasma cell neoplasm. However, all patients have monoclonal immunoglobulins or free light chains, which is found both in urine and in serum. All right. So bone marrow and most show an increase in number of plasma cells, which may secrete precursors of AL protein. And this may represent plasma cell dyscrasias characterized by production of an abnormal protein instead of production of tumor masses. Right? So this can act as a diagnostic marker in case of such plasma cell neoplasms. Right? Now, in secondary systemic amyloidosis, it's also known as reactive amyloidosis because it's seen in chronic inflammatory states or where there's a tissue destruction process. So it's often associated with chronic inflammatory states such as tuberculosis, bronchiectasis, and chronic osteomyelitis, all right? Or also in autoimmune conditions such as rheumatoid arthritis or ankylosing spondylitis, or also in heroin abusers where there's chronic skin infections or abscess formations, or non-immunocyte derived tumors such as renal cell carcinomas, that's RCC, and Hodgkin's lymphoma. All right. And then there's hemodialysis associated amyloidosis. So patients with chronic renal failure on long-term hemodialysis show high levels of beta-2 microglobulin in the serum because it can't be filtered out through the dialysis membrane. So it gets deposited as amyloids. Right. Now, moving on to hereditary amyloidosis. Well, one, it's basically heterogeneous group of amyloidosis, which is often rare, and it's seen in certain geographic areas, such as in familial Mediterranean fever. It's most commonly seen around Mediterranean areas and in the Middle East, where actually you find AA type of amyloids being deposited. So that's amyloid-associated amyloidosis. So it's often the result of an autosomal recessive disorder, where recurrent attacks of fever accompanied with inflammation of serosal surfaces, such as peritoneum, pleura, or synovial membranes are affected. And the gene which encodes for the protein, pyrin, it's called pyrin, that's Pyrin, because it's so named because it's related to fever. Let me just write that down so you can remember it better. Okay, so you find pyrin protein is affected, causing the fever-like state, right? And the spinal protein is often used to regulate inflammatory reactions by producing high levels of pro-inflammatory cytokines, such as interleukin 1. All right. And then there's familial amyloidotic neuropathies, as I described earlier, where it gets deposited in the nerve bundles of peripheral and autonomic nerves. Yeah, well, you find on examination, on biopsy, you find fibrils being deposited here, often containing mutant transthyretin proteins. All right. Now, moving on to localized amyloidosis, you find endocrine amyloids. So, but basically, localized amyloidosis is not as systemic as its other contemporaries because it's localized to a single organ or tissue. It's limited. It can either be grossly visible as nodular masses, or you can detect it only on microscopic examination, such as when you do a biopsy. And you often find it deposited in lungs, the larynx, skin, bladder, or tongue. All right. So in endocrine glands, you find endocrine tumors such as carcinoma of thyroid, islet tumors of pancreas, pheochromocytomas, which affects adrenal glands, and undifferentiated carcinomas of the stomach. And it can also be seen in islet cells of Langerhans and pancreas in type 2 diabetes mellitus. And another type of localized amyloidosis is seen in senile systemic amyloidosis, where you find transthyretin proteins being deposited in cardiac tissues. So as a result, you have cardiomyopathies and arrhythmias. And you find on examination the transthyretin molecule being deposited as the amyloid. And it's most commonly seen in elderly patients between 70 to 80 years. Right? Now, moving on to the morphology of amyloidosis. So, the main organs being affected in primary amyloidosis, you find the heart, the gastrointestinal tract. That was supposed to be the intestine. Let me just write GIT here. GIT. Right, GIT, lungs, peripheral nerves, skin, and the tongue. Just write tongue if you can't identify that as tongue. Alright, so you find the heart, gastrointestinal tract, lungs, peripheral nerves, skin, and tongue being affected the most. Alright, in secondary amyloidosis, you find kidneys, liver, spleen. That's my drawing of a spleen. Spleen, lymph nodes, the adrenal glands, which are specifically circled over here, adrenal gland and thyroid gland being affected the most. All right. So now on gross appearance, what do these affected organs look like? So you find large amounts of proteins accumulating in these organs, which causes them to be enlarged, firm, and have a waxy appearance. All right. Now, cut surface of these organs shows the waxy appearance, whereas when you apply iodine across the surface, when you paint the surface with iodine, it turns yellow. Then the moment you add sulfuric acid, it can either turn blue or violet in color. All right. Now, on microscopic examination, you find with eosin and H&E staining. On H&E staining, you find extracellular deposits being present, and you find progressive accumulation of amyloid proteins in these extracellular spaces, which puts pressure atrophy of adjacent cells. So as a result, the normal cells, they show atrophy because of the increased pressure upon them. And on appearance, you find amorphous deposits, which are often eosinophilic and hyaline in appearance, or glassy. And it's often found in the extracellular spaces. So it's an extracellular substance. All right. Now, moving on to staining properties. Use different stains apart from H&E staining. The most commonly used one is Congo red stain, which is a special stain that's used for diagnosis of amyloidosis. And when you examine under ordinary light, you find red or pink color. All right. I even color it a bit pinkish. So you find red or pink deposits. And on polar microscopy, you find apple green bifurcations. All right. So it's dichromatic staining, which is often apple green in color. Other stains which you can use are Van Giesen stain, right? So it gives a khaki color. Or Alcian blue stain, which is commonly used for glycosaminoglycans type of amyloidosis, which is the minor form. And periodic acid Schiff can be used, and you find a pink color. And methyl or cresal violet can be used, which produces a metachromatic pattern of staining, and it gives a rose pink color. All right. And thioflavin T, it often fluoresces under UV light, so you can use it specifically under UV light to diagnose it. And immunohistochemical staining can be used to differentiate between AL, AA, and ATTR types of amyloidosis. All right. Now, moving on to the specific pathologies of different organs which amyloidosis can affect. So now, the most commonly affected and serious complications are that of kidneys. So amyloidosis in kidneys. Initially, for the most part, you find that the kidneys appear to be normal in size and color. All right. So only in like the really late stages, advanced stages, you find a decrease in size. Right. This is often because of ischemia, and you find vascular narrowing because amyloid deposits are seen within arterial and arteriolar walls of the kidneys. All right. And kidneys, for the most part, as I mentioned, shows a normal size and color. The reason why this happens because if you look at the kidney, suppose an amyloid gets deposited here. The more pressure atrophy it causes to the surrounding tissue, the more the amyloid protein takes up the space. So for a very long time, the amyloid protein actually takes up the vast empty spaces of the kidneys, thereby maintaining the same size of the kidney. All right. There will be a decrease in renal function, but the size of the kidney remains the same. And actually, this is a common entrance question, in case you were interested. Why doesn't the size of kidneys change in amyloidosis? All right. Only in later stages, it decreases in size because of ischemia. And on microscopic examination, you find AL or AA protein deposits seen in the glomeruli. The glomeruli is most affected, especially the mesangial matrix, which is seen extracellularly, and the basal membrane thickening, which is most common findings. All right. And you find narrower capillaries, and progressive accumulation of these amyloid proteins causes obliteration of capillary lumen and glomerulus with broad ribbons of amyloid protein deposits. All right. And you find peritubular interstitial tissues and arteries and arterioles in the kidneys showing these broad ribbons of amyloid deposits. All right. Now, next organ to be affected the most is the spleen, where you can find moderate to marked splenomegaly. Now, you find two types of spleens over here. One is sago spleen, where you find deposits of splenic follicles which appear as sago granules across the surface of the spleen. And the walls of arterioles in the white pulp are where you find these deposits. All right, that's a sago spleen. In lardaceous spleen, you find deposits of amyloid in the walls of splenic sinuses, and it resembles pig fat, which is why it's called lardaceous spleen. Lard meaning fat. All right. So when the amyloid protein deposits in arterioles of white pulp, you get sago spleen. When it deposits in splenic sinuses, you get lardaceous spleen. All right. Now moving on to the liver.